dizziness, and sometimes even seizures in the dental chair. So what happens is, no, you need to understand when the patient steps into the clinic, two things that we need to ask is, one is, are they diabetic? And the second thing is, what are the medicines are they taking for the diabetes? If the patient is taking an insulin or a sulfonylurea drug, then there is there is more risk of hypoglycemia. So a patient who is under insulin, we can't treat the patient or have the patient for a long time in the dental chair, because there are chances that the patient have hypoglycemia. When the patient has a metformin or thiazolidinediones drugs, what actually happens is, there is no risk for us to get really panic when we are treating in the dental chair. The patient will not fall for hypoglycemia with these two drugs. So what should you do? What the do's and don'ts of your diabetic patients in your dental chair? If the patient is having insulin, they are taking insulin, what we need to remember is, ask the patient about the onset. We need to know what type of insulin are they taking. So based on that, we should know the onset, peak, duration, number of doses, and the last dose that the patient has taken. So now, after knowing everything, what happens when the patient falls hypoglycemic or if they faint in the dental chair? So, okay. Or if they're saying dizziness or anything, if the patient is oriented, conscious, probably we can give 15 grams of oral carbohydrate. The second thing, next to the glucometer, the next thing that you should have always in your clinic is glucose. So you can give 15 grams of oral carbohydrate. In case the patient is not actually conscious, you need to give IV of 25 to 30 ml of 50% dextrose. So continued by 12.5 to 15 grams of dextrose. Now sometimes even this when we give drips, that may take a little bit of time for the patient to get recovered. What we should do immediately, if it is like really a panic condition, what we need to do is, we should inject 1 mg of glucagon IV. So the next thing that we should have in the clinic, in the emergency crash cart, is 1 mg of glucagon should be there in your clinic, where you need to inject it IV. So again, you can do it in IM as well. What exactly it does is, it immediately releases glucose from the liver. So the patient will be we can rescue the patient. So, okay, so the next condition is hyperglycemia. Yeah, ketoacidosis is a common condition in the hyperglycemia, but we need to understand it is a life-threatening, but it is very, very rare. So what all the other precautions you should tell the patient is, please do take the food and your insulin before the treatment, and try to avoid the long procedure and limit the size of the surgical field. Do not have a bigger surgical field. So these are the evident researchers who has done study. The next important topic, and a very interesting topic, most of the men ignore and women focus, would be the female hormones and their influence, because I think most of us who are here are like kind of married. Most of the time we have all mood swings, tension or stress or whatever it is. We have the job from morning, making a cup of coffee to the end of the day, closing the gate with the lock. It's all our responsibilities. Along with that, we have an added stress as something called hormone, which will just travel along us throughout the life. And I request all the men who are here to take home message more than this talk, what it is, to understand what every woman in your house go through and support her phenomenally. So to get into the topic again, it's a female hormone and the periodontal health. Again, hormones, does it have an influence on the oral health? Yes, it does have an influence on the oral health. So microbiologically, I don't want it again to go so theoretically. We will have a microbiological change, a vascular change, a cellular change, and the immune change because of the female hormone in the women's body. So clinically, what all can you see? You can see an erythema, you can see an edema, shiny surface, raspberry appearance, tendency to bleed, an anterior effect. Mainly it affects the anterior region. Sometimes in your clinic, if you probably see elderly geriatric patients, they come and they say, I have a burning sensation, and it is very, very soft, smooth, shiny, and when whatever I eat, I am not able to take spicy food at all. It's just burning. And when you clinically see, you cannot see much about, to tell about whether periodontitis, no, the tissue will not have a pocket or anything, those kinds. That could be because of the menopausal syndrome, hormone. So what exactly we need to do in this is, what we need to understand is, when we start from the puberty, we will have a dance balancing up of hormones in our body. So the important thing with hormone that we need to really understand is the low birth weight baby. So what exactly happens is, because of the bacterial vaginosis, there are some organism which will be replacing the lactobacilli, that is a good bacteria, which will release the pro-inflammatory cytokine, and those cytokines will cause chorioamnionitis or amniotic PGE2 production. So when these two are produced, what happens is there will be a premature rupture of the membrane, so which finally leads to a preterm labor. Again, preterm labor leads to, eventually will end up with a low birth weight baby. Again, when we tell low birth weight baby, it can, the range can be, the frequency can be from the death or a neurodevelopmental disability. It can be serious one or it can be on a lighter note. So we need to understand periodontitis have 5 times an increased risk of delivery before 35 weeks and 7 times increased risk of delivery before 32 weeks. So this is something what we lack in the practice is the awareness of the dental problem for the patient. Patient take dentistry so lightly. Unless and until they have a swelling, they have a pain, they have something which is troubling their day-to-day life, they don't step into the clinic. So these are the few things, when they come for the regular checkup itself, these are the few things that we need to make them aware about. So especially with women, what are the things that you should do when the pregnancy patient comes into your clinic? So first thing that you need to make them understand, any inflammatory response can exaggerate the pregnancy associated hormones. So the treatment should be done only in the 2nd and 3rd trimester, and the patient is supposed to be treated in the supine position because of the obstruction of the vena cava and aorta. So when that happens, what exactly happens is the patient will end up with supine hypotensive syndrome and the patient can have loss of consciousness. So what are you supposed to do? Avoid long procedures for the pregnancy patients, and because to avoid the obstruction of vena cava, ask the patient, the pregnant women, to slightly elevate the hip and sit in the dental chair 5 to 6 inches during the procedure, so we can avoid it. And as usual, as a universal tip, please do avoid the medication and the radiation exposure. Yeah, the next system would be the thyroid, endocrine, thyroid and the parathyroid. I think we are much familiar with the hyperparathyroidism, hypoparathyroidism and all. So what do you need to really remember is, if the patient is telling that the patient is having a thyrotoxicosis, please do not do any dental treatment unless and until it is controlled. So basically with hyperthyroidism, you need to remember tachycardia and arrhythmia patients administer adrenaline with caution. So the chances of, in thyroid patients, the chances of excessive sedation on sedatives or narcotics are common. So try avoid these patients to be treated with the sedatives. So again, hypokalemia and hyperkalemia calcemia patients will have cardiac arrhythmias. That is something we need to be aware about. Now, the next thing would be adrenal insufficiency. We very rarely hear about adrenal insufficiency. The most common thing that we hear on day-to-day life would be heart attack, cardiac arrest. Especially after COVID, cardiac arrest has become a common thing. It is like one idli and dosa, we tell cardiac arrest. That's very commonly, we are like ending up losing all our near ones and the dear ones. So finally, we always tell, though we refer to cardiac arrest, we don't understand what cardiac arrest could be because of several things. Now they even saying it could be because of the injection for the COVID, whatever we have like taken. It could be because of the vaccine as well. But what could be the reason of cardiac arrest? I mean, in my college, probably before 15 years, it was on a Saturday, there was a guy who came, who could be, he was like young and fit for a wedding, for his wedding. So probably could be 25, 26 years, well built, who was like, I think a software IT field or something, and his cousin is like a CRI in my college, so he wants to get a cleaning done, nothing much, a scaling done. So he came along with his mom, and the mom is like waiting outside. I think they are in the process of seeing the girls for the wedding. And when he came and they started scaling, within 5 minutes or something, he became really restless and lots of sweating. So immediately they called people from the next department. Adjacent department is oral surgery. We called people from there and they rushed up, and when we saw, we lost the patient. There was nothing. We couldn't even understand what exactly had happened. You know, in the dental chair, in no second, in no minutes, we really don't know what exactly had happened with the patient. Finally, when we took him to GH, what we really understood is the patient could have adrenal insufficiency. That's what they said. So we take lots of things very lighter. We always say cardiac arrest, heart problem, heart leda problem irka, matra saapidringla, adukku edavadhu irka. These are the usual questions that we ask. But we need to understand or remember adrenal insufficiency is something we are skipping out on a routine basis, and we need to remember about. So that is something where we need to focus on. So on the first thing in adrenal insufficiency, what we need to remember is acute adrenal crisis. Okay, so though we commonly tell it as like a cardiac arrest, the patient, we lost it by a heart attack or something. What exactly led to that adrenal insufficiency is the patient can have an acute adrenal crisis during the dental treatment. So that is when the patient has peripheral collapse, chilling out of the peripheries, you know, hands and legs, that we usually have during my exams. I don't know about others, I have it in my own. You know, when we see the question paper and we know the detailed answer in the question paper is not known, the first thing that we can see is like chilling out of the hand, you know, and that is something that basically that's because of the stress. Yeah, so peripheral collapse. So what we need to understand is there will be a corticosteroids production which is helping us from the stress. That is something which is helping us as a natural mechanism. So what actually happens is when the patient is already under steroid therapy, we need to remember when the patient says I'm diabetic, when the patient says I'm cardiac patient, we will give full focus to the patient, but we also have to understand when the patient is taking steroids, we need to give a pause and understand what the patient body mechanism is going to be. So usually what happens is for these patients, for any patient who is like really tensed or apprehensive or a long procedure or those things, prophylactic steroids for adrenal, especially the patients who have a problem with adrenal insufficiency, prophylactic steroids before dental procedure has to be given. That is 5 to 20 mg per day has to be given to maintain the adrenal reserve after the termination. And the recent evidences has suggested if in case even we have not given a prophylactic antibiotic, within 2 hours of the procedure the patient has to take the steroid. So now again, we need to give a profound LA to remove the stress of the patient. Again, profound, it's an English thing. It's a deep LA. When we give it a very strong and a deep LA, again it reduces the stress. Now, low adrenal function, blood loss or a long procedure, supplements are mandatory. We need to give mandatory supplements of steroid for if there's going to be a long procedure, a lot of blood loss procedure or anything. And the next thing is rule of 2. Rule of 2 is nothing but if the patient is taking steroids within last 2 months for more than 2 weeks of 20 mg per day, we need to double the dose of steroids before the procedure for the patients. Because the steroid that we are giving before will not be enough to cope up with the stress mechanism. So we need to, if these conditions, the patient fall into these conditions, we need to double the dosage of steroids. So again, in the dental chair, if it happens, what are we supposed to do? So first thing is, what we will usually do is, especially the PGs, what we will usually think about it is, we need to finish the quota. So just எல்லாமே முடிஞ்சிருச்சு இன்னும் 5 நிமிஷம் தான் மேடம் ப்ரொசீஜர் முடிஞ்சிரும் 5 நிமிஷத்துல பேஷண்ட்டும் முடிஞ்சிரும். So we need to be careful that terminate the procedure wherever you are in. Please terminate the procedure and administer oxygen for the patient. Again, the fourth thing that you have in your clinic, in your crash cart will be oxygen cylinder. Oxygen administration has to be given and the patient has to be placed in the supine position. And the next emergency drug would be hydrocortisone, very mandatory drug that every clinic should have. 100 mg of hydrocortisone sodium succinate IV over 30 seconds will help us to revive the patient. If it's like the patient is little disoriented, discomfort, you can probably think about IM. But then adrenal insufficiency happens with fraction of second, so IV of 100 mg hydrocortisone sodium succinate will help. So these are the recent researchers. So the next system that we will be looking into will be hematological disorders and periodontal. This I think we will go through in our day-to-day life. I don't want to go in detail about what exactly everything is. The various hematological disorders, one is neutropenia, where the blood neutrophil count will be lesser, and always remember, for us to do any procedure, the neutrophil should be more than 1500. Again, agranulocytosis, again a lack of granulocyte, again absolute neutrophil count will be less than 100 per micrometer. Again, we call agranulocytosis as neutropenia or granulocytopenia as well. What are the symptoms that we can see in agranulocytosis is ulceration, mucosal isolated necrotic patch, it will be like an isolated patch in the mucosa, gingival hemorrhage, gingival necrosis, and increased salivation along with the fetid odor. So the next one would be leukemia. Again, in leukemia, it is like you have acute myeloid and the lymphocytic. Again, it has chronic and acute. Again, with leukemia, the patient will end up having anemia, thrombocytopenia, and neutropenia. All these would be like a combo. So again, the symptoms in this: leukemic gingival infiltration, enlargement, cutis, gingival bleeding, oral ulceration, acute gingivitis, and gingival bacterial infection. Yeah, of course, the WBC count is coming down. So obviously, the defense mechanism will be compromised. So this is, I think, a very common thing because we use it for everything, especially nowadays. The anemia is a term very commonly used in most of the house when we say mudi virudha. When we are getting hair loss, more than anything else, when we have a hair loss, the first thing that we think about would be anemia. Yeah, so anemia, the oral manifestation would include candidiasis, ulceration, lichen planus, stomatitis, atrophic glossitis, aphthous ulcers, etc. So we have, as we all know, we have different types of anemia as well. Again, thrombocytopenia, when we have a less platelet count, is thrombocytopenia, and the symptoms would have petechiae, ecchymosis or heavy menstruation, dizziness, nausea. Basically, the platelet count is less, so the bleeding time and the clotting time will get altered. So what we clinically see is soft, friable and swollen gingiva, gingival bleeding, petechiae and hemorrhagic vessels, and that vesicles we can see commonly in the palate, buccal mucosa and tonsilla pillar. So what we need to understand in this side is when we are examining the patient orally, when we say petechiae and hemorrhagic vesicles in the palate or the buccal mucosa or the tonsilla pillar, we need to directly connect with the thrombocytopenia before doing any dental procedures. So how are we going to treat these patients? So now we always think, okay, neutropenia or granulocytosis or anemia, these are the conditions we need to really keep in our mind before treating for the hemorrhagic disorders. We also need to understand when we have or go through these symptoms like jaundice, the patient just comes to your clinic, the patient says I'm absolutely fine systemically. But when we see an LOIs, when we suspect a jaundice or a petechiae or ecchymosis or subcutaneous the bleeding or a very more of severe gingival bleeding or a severe gingival enlargement, always make a point, you ask the patient to do the tourniquet test. So this test will help you to analyze and understand whether the patient is having any disorders, hemophilic disorders are there or not. So these are the symptoms that you need to keep in your mind. So again, in hemophilia factor 8, I don't want to go what is not there and all. So basically, what you need to have in the clinic in your crash cart would be 1-D-amino 8-D-arginine vasopressin. When you are treating a hemophilia 8 patient, even if you don't have it in your crash cart, if you are going to treat a hemophilia patient, have this in your clinic. So you need to give a parenteral administration of this. Again, for hemophilia B patient, a purified prothrombin platelet concentrate has to be administered before any dental procedure. So again, for the von Willebrand factor, in the mild forms, we can again administer 1-D-amino 8-D-arginine vasopressin when we are doing an extraction or a periodontal surgery, or you can even give a cryoprecipitate infusion for a von Willebrand patients. So precautions to be followed. Hemophilic patients, make sure you do a proper complete wound closure, pressure application, and anti-hemostatic agents has to be kept in your clinic. Again, in your crash cart, oxidized cellulose and bovine collagen is must that you should always have in your patient. Sometimes we don't even know why are they bleeding. Some patients bleed. For heaven's sake, we really don't know, we can't correlate, they don't have a hemophilic disorder, we don't know what exactly has gone wrong, but the patient will have continuous bleeding, like, though I am working in a cardiac hospital where, I do get calls at like 2 o'clock or 3 o'clock in the night saying the patient is bleeding. Whatever extraction you are doing, the patient is bleeding. So we also attend the emergency. So for us to at least sleep peacefully, the patient who bleed more, please do pack it with the oxidized cellulose and suture it and send the patient. So again, we can have an antifibrinolytic agents or prescribe antifibrinolytic agents like E-aminocaprioic acid or tranexamic acid. This tranexamic acid, probably you can keep a note and keep it. The tranexamic acid is available as a mouthwash. So for the extraction patients, when they tend to bleed more, you can ask them to just do a mouthwash with this, which helps to a very large extent. So the other conditions for the bleeding, again, liver disease patients, alcoholic patients, vitamin K deficiency patients, and the patient who is under antibiotics for a long run, you can expect bleeding on these patients as well. So for the liver disease patients, why? Because we have most of the clotting factor getting associated with the liver, and production gets affected and coagulation is affected, and the same way coagulation is affected for the alcohol patients. Same as well for vitamin K. And for the antibiotics, what happens is it alters the intestinal flora, which affects the vitamin K production and which again affects the coagulation. So how do you manage these patients? As we always say, PT, PTT, BT, bleeding time and the platelet count, we need to take a check of all these measurements for the patient and try and do a conservative procedure for these patients than non-surgical procedure. We always have to remember there's something called INR. So this INR is international normalized ratio. This INR is something which helps us always to be in the safer side. If you feel the patient is going to or tend to bleed more, please do check for the INR. Okay, if the mostly for the cardiac patients, they will try, especially for the valvular patients, they will try and keep the INR somewhere close to 7 and 8, especially for the mechanical valve patients. But we are not supposed to touch the patient dentally unless and until we can achieve with the patient have INR less than 3. So if it is more than 3, it is not advisable for us to treat. So it should be less than 3. So again, for the non-surgical procedures, it should be less than 3. For the minor surgery and extraction, so one extraction or a mild frenectomy or something on those note, a very minor surgery, the INR should be less than 2. And the platelet count should be greater than 80,000 per cubic millimeter. If we are doing a surgery or multiple extractions, in those cases, the INR should be 1.5 to 2. Again, when you have to achieve this, it is not that easy. What really happens is the patient, the cardiologist don't understand the importance of dental always because they hold the upper hand. So what? They will not accept us to, even if you request, they will not, for the mechanical valve, there are two types of valve, that is biological valve and the mechanical valve. Especially with the mechanical valve patients, they will not allow the INR to come below 3. If that is the case, you can't treat the patient. because I had a worst experience in my hospital where the patient is basically under a mechanical valve patient. So for this particular patient, the patient is under warfarin. So what happened is we had the patient for 21 days in the cardiac hospital just to control the dental bleeding. It was a worst nightmare because the doctor doesn't wanted to bring the INR less. So you can't treat. So one extraction, it's just one upper 2-7 extraction. I will completely control the bleeding and send the patient with the suture. The next day you can see an egg yolk kind of bleeding falling in the tongue. Next day morning when the patient wakes up. So it was like a nightmare for us, a task for us to treat, and finally with help of some doctors we could bring the INR at least close to 2.5 or something. And what exactly we did is, we are not supposed to do this actually scientifically. We say warfarin is something completely which blocks vitamin K. So we are not supposed to block vitamin K give vitamin K to get produced in the body, especially for the valve patients. But what we did is, we used several agents to control the bleeding. Nothing, we couldn't do anything. What we did is, we got vitamin K injection and poured vitamin K injection in the gauze, and locally we placed in the socket. That's it, the bleeding stopped. So the patient is so sensitive, and with just the local application of vitamin K in the gauze for the warfarin patient helped us phenomenally. So we are not supposed to inject vitamin K again. So these are few things practically what we understood with the practice. So how do we manage the patient? Wound closure, pressure application, oxidized cellulose, and okay, 3 things that you need to remember is, the patient who comes, if in case the patient is taking aspirin less than 325 mg, if they are taking aspirin, greater than 325 mg, what are you supposed to do is, discontinue the drug 7 to 10 days prior to the surgery. If the patient is taking heparin, discontinue you are supposed to do the procedure only after 4 to 8 hours. Ideally speaking, 6 hours at least you need to wait. You can't do any procedures in the patient if the patient is taken heparin. And if the patient is under NSAIDs, sometimes for pain or inflammation, we take NSAIDs, like a normal thing, like over-counter drug. So we take NSAIDs. Even NSAID have an efficiency to inhibit the platelet function. So it has a short-term inhibition. So basically, as I told you, this is something which I explained to you already, warfarin or dicumaril or vitamin K antagonist. So for those patients, you need to remember that it inhibits the production of vitamin K dependent factors like 2, 7, 9 and 10. So vitamin K deficiency will be predominant in this patient. Again, with thrombocytopenic purpura patients, scaling and root planing can be done. If it is, you can do it if the platelet count is greater than 60,000 cells, and surgical procedures can be done only if they have greater than 80,000 cells per cubic millimeter. Again, non-thrombocytopenic purpura, they will have a very fragile blood vessels. It tends to break very easily. So please do give pressure directly for 15 minutes, and in these patients, it's not advisable to do any surgical procedures. Whichever theory supports, no, please don't attempt to do this. Again, agranulocytosis. Agranulocytosis have a period of emission and period of active period. Again, do the treatment during the remission period, extract with the physician approval, and goggle your mouth. For these patients, give chlorhexidine mouthwash because they're more prone for the infections. So give them chlorhexidine mouthwash, and scaling and root planing under antibiotics, definitely, because the WBC are very low. Give them under antibiotics. Again, the next one, leukemia, periodontal treatment advised before the surgery, extraction at least 10 days before the chemotherapy, scaling and root planing advised, palliative treatment can be given for ulceration and mucositis. Systemic antibiotics has to be given for leukemic patients for the secondary infection. Again, the patient have candidiasis, nystatin and clotrimazole. Again, for acute leukemia, please don't attempt any procedures. Scaling and root planing for the chronic procedures. So a very important thing, that is a cardiovascular disease. Yeah, the cardiovascular can present itself in various conditions, coronary artery disease or valvular disease, heart failure, CHF, or electrophysiology, abnormal electrophysiology of the heart, or the ischemic stroke. It can be anything. We commonly say heart attack, that's the only term we know, but it can be of any form. So we need to understand the first one, coronary artery disease, is very, very closely related to the periodontal conditions or the dental. So what happens is, it affects the endothelial cells, macrophages, blood coagulation, and the lipid metabolites. So always remember, the periodontal